So, dear all, this is the last episode before the summer break. We do it because one of you asked for more explanation about this muscle retracting sign. So it appears that it is a very difficult situation in ESD, in particular lesions, and therefore it was a very good opportunity to do an episode exclusively on this. We thank you for being with us, and now we are more than 3,500 in the school, the endoscopy school. So please feel free to ask for more precise thing, and now we are beginning to talk about this muscle retracting sign. So first, this Mr. sign, muscular retracting sign, was described by Takashi Toyonaga in 2015. We show at this time in the first lecture that it was correlated with the nodular aspect of the lesion, and we can see that when the muscle retracting sign is here, the en bloc resection rate, the R0 resection rate are really decreased, and the perforation rate and bleeding risk after the procedure are increased. So it is a difficult situation. In this study, there was a depth of invasion of more than 75% over the 1,000 usual target or threshold of 1,000 microns. So we have deep invasive cancer in 75% of the cases in this first report, in this first article talking about this muscle retracting sign. After, what is it clearly? How can we define this muscle retracting sign? So it is a feature which is observed during endoscopic submucosal dissection, because we try to find a layer between the muscle and the dysplasia, the nodular lesion. But in fact, in this particular situation, there is no more submucosa at the center of the lesion where the muscle is attracted, because probably when it is not a very deep invasive cancer, you have a very large lesion, very nodular lesion, which is fed by a large vessel in the middle. And this large vessel is a kind of tutor, a kind of structure where the nodule is organized around. And you have this nodular lesion that is finally jumping from one side to the other side around this fixed vessel. And we could imagine that it creates a lot of traumatism around the lesion, sometimes probably some ischemic problem of the lesion, with a strong fibrosis and an attraction of the wall, which is progressively attract into the lesion with a disparition of the submucosal layer. So in the definition, we could say that there is a central feeding vessels when it's not a T2 cancer. If it's a T2 cancer, this vessel can be completely destroyed. But if it's not a deep invasive cancer, you will find a very large vessel in the middle, surrounded by fibrosis or scar or very scarry tissue, and no more layer between the mucosal layer with the lesion and the muscular layer, which is pulled into the lesion. So the problem is that you will not have any submucosal layer at the middle. So if you want to be R0, you will have to go into the muscle. So I think it's common to have at least a muscular damage in the center. If not, the big risk is to damage the lesion and not have an R0 specimen in the middle. So the key point is that you have a neoplastic lesion with a very big shape compared to the area involved. It makes very large vessel in the middle. It attracts the muscle. The lesion is moving around this point, and the submucosa progressively disappear, and at the end you have a kind of fusion of the mucosa with the lesion with the muscle. This is, for me at least, the definition of this. This muscle retracting sign was studied by the French group and coordinated by Jérémy Jacques in Limoges. We saw in our database that on 840 colorectal lesions of more than 20 millimeters, this muscular retracting sign was seen in 27% of the cases. The predictors were a macronodular morphology, and the odds ratio was at 6 if the lesion is over 40 millimeters with a large nodule of more than 40 millimeters. So the muster sign, the muscular retracting sign, becomes more frequent when the nodule is larger and also when the lesion becomes more difficult. It is conventional to have a central feeding vessel, a fibrotic scar tissue, a loss of submucosal layer, and a muscle pulled upward into the lesion. In most cases, the fibrosis was visible in 95% of cases, and in 5 to 10%, we clearly see an invasion with invasive cancer into the muscle, which is not completely a muscle retracting sign, but more a deep invasion. The deep submucosal invasion is more seen in the sigmoid location and when you have Ginette tree pattern or connectory pattern at the upper part or at the visible part of the lesion. What we want to say is that muscle retracting sign should not be enough to send the patient to surgery, but the combination of Ginette tree pattern and, for example, if this Ginette tree pattern is very small and you want to try an endoscopic resection, if you have a muscle retracting sign and a Ginette tree pattern, probably it's better to stop than doing a large perforation under a deep invasive cancer. So if there is no lesion that is apparently a deep invasive cancer, no Ginette tree, you can try your resection and see if you are able to pass under the muscle retracting sign without touching the lesion. If you have a combination of both Ginette tree or connectory pattern and deep invasion or very difficult muscle retracting sign, you should probably stop your procedure. For me, there is a big difference between muscle retracting sign in a nodular lesion with a feeding vessels at the middle and a T2 cancer, sometimes not nodular. So if you see a non-granular LST with a large area of connectory, Ginette tree pattern, and no submucosal layer at the middle, for me it is not a muscle retracting sign. It's not the muscle that is going to the lesion because of the nodular shape and the attraction of the muscle, but more an invasion of the lesion going down to the muscle and fixing the muscle. So it is probably completely different, and the management strategy for a muscle retracting sign under a nodular apparently benign lesion should be probably an attempt of ESD by a very expert guy. If on the opposite you have a lesion which is not nodular with a deep invasive pattern in the surface, you should probably not try to do ESD and go more to EUS, MRI in the rectum, or if you really want to have a diagnostic strategy in the rectum, you can probably turn to intermuscular dissection. But once again, it's different. It's in research now we are looking for combination between endoscopy and adjuvant therapy. It's not a common practice to try to do endoscopic resection for lesion with large areas of deep invasive pattern where endoscopy alone will not cure the patient. So for me, clearly different between muscle retracting sign in nodular lesion and invasive cancer, which are not nodular. And sometimes you have nodules with invasive pattern. Should we try or not? It's a good question, and it depends of your expertise, the impression, the size of the deep invasive area, etc. So how to defeat muscular retracting sign is the question here. How can we succeed of this resection? I will show you three key technical principles, small principles, and after we will go in two different approach, two different strategies, tunnel approach or multipolar traction approach. I have not the answer of which one is better, but I will show you different strategies and different choices that can help you to treat the patient. So first, it is the blue-to-blue strategy. It is very difficult to pass through the muscle retracting side because you have no more blue layer to help you to see where you should cut and how you should pass between the submucosa on the left, the submucosa on the right. So my advice, if possible, is to try to inject a lot the two sides of your muscle retracting side. Whatever the strategy chosen, I mean, if you do a tunnel or if you do a multipolar traction strategy, you can, in both strategy, try to inject on the right and to inject on the left on the two sides of the muscle retracting sign in order to have a blue-to-blue strategy. It means when I don't know how to pass in the middle, I will try to find blue in the left. Here you will see inject a lot of blue here in the left, and then try to join the blue from the blue and have a cutting line which is virtual because you don't see it very well, but you can try to join those two sides, and it will help you to cut the muscle without going too deep. If you just cut the muscle front of you with a large muscle retracting sign, sometimes you will do a very big perforation. So for me, trying to join blue to blue, controlling the bleeding during this phase will help you to see better and will reduce finally the area of muscle that you finally cut. And I prefer the multipolar traction strategy for this, and I always try to open the space on the left and on the right, injecting a lot of blue, and we will see that, for example, Jeremy likes a lot to use high pressure injection for this kind of difficult situation because you will increase the space in the two sides. Injecting a lot with blue will help you to try to advance relatively safely, controlling the vessels with view, with visibility, and then trying again to go in the two sides of the blue and sometimes joining the two blue area by yourself. But nevertheless, even if you try to precoagulate, most of the vessels are very difficult to detect within the fibrotic area in the center of the lesion. So you should be prepared to deal with bleedings and sometimes relatively big bleedings at the middle. So trying to expose right and left side of the blue to have only the vessel at the middle and be ready to catch the vessel with a forceps is for me important in these difficult lesions. Next case, underwater strategy may help, but it will help you to see better, to have a better buoyancy of the lesion, to have less fat or fibrosis coming to your lens, etc. But on the opposite, it's sometimes difficult if you are not really expert with bleeding management to have water with a lot of blood into. It will ask you to remove all the water and become again in a gas situation. So please try underwater, but try also to remove some water when you are dealing a large vessel into the muscle retracting sign. Prepare yourself to a big bleeding, and then prepare yourself also to have a situation where having a lot of blood in water will make you in trouble. So I would say at the beginning of the procedure, etc., underwater strategy is helping. We know it. It's very helpful for many situations. But at the middle of the situation, try to have something like traction or tunneling to expose within gas the area of the center where you will have less trouble in case of relatively intense bleeding. High pressure injection can help. If you have more pressure to inject the two blue, you will probably see better the center and the feeding vessel of the muscle retracting side. So combining traction to expose the center and high pressure injection like Jeremy is doing here is probably also a good idea. And now I will go in the two different strategies that are common, I would say, in muscular retracting sign strategies. Either you are targeting first the muscle retracting sign by doing a tunnel in direct viewing, sometimes also in retroflexion to reach the center and try to cut first the muscle retracting sign using the blue to blue strategy to connect the two sides of the resection. It is one first strategy, and I will try to show you this kind of strategy we did before. So always trying to have blue and blue. So blue on the right, injecting it deeper than the muscle retracting sign. Trying to go slowly to the opposite side. So we see some blue in the left. We see progressively the muscle retracting sign which is into the lesion. So always I inject at the left part, trying to create blue, at the right part, and at the end we have to cut. And you see that it's sometimes difficult to see the whole area and to see how deep we should catch and how deep we should cut. So for me, I would say some very expert guys will probably manage to do it without bleeding. I would say that for muscle retracting sign, bleeding is part of the procedure in many cases, and you should be ready to deal with it. So tunneling is an option, but once again, it is important to expose the two sides of the muscle retracting sign and to try to cover it, to open the space, and then after, when you pass through this muscle retracting sign, you will be better and life will be very easy after this very high challenge of passing through this muscle retracting sign. Second strategy, which is for me the most evident. It is also the most evident if you ask to AI to deal with a muscle retracting sign with a fixed point at the middle of a lesion. If you ask to ChatGPT which is the strategy which is the most logical, it is also the one that is chosen by ChatGPT, but it's my ChatGPT, so it could also be biased by the fact that I prefer traction. I don't know, but for me it is still more logical to try to remove all the blue layer around, track the four edges of the lesion to the opposite side, and finish by this big bleeding at the center of fibrosis when I see everywhere what remains at the center. So I will probably damage the muscle at the middle, okay, because traction will pull the muscle, but it's at the end of the procedure, and by damaging the muscle at the middle, I will not damage the specimen, and therefore what we want is to be R0, because if there is cancer, it is probably at the middle also, where the submucosa is totally destroyed or disappeared. So we should be R0 at this central part of the lesion, and by doing the multipolar traction, letting only the muscle retracting sign at the end, we will probably have a small muscular damage or complete perforation, but sometimes it's thicker on the muscle retracting sign. The muscle is more thick at this area than in the other part of the colon. So most of the time you will damage the muscle but see a layer under, and you will not expect a very big perforation. it's the end of the procedure, so you can close easily. The lesion is not very difficult to deal with at the end because everything is done around. So you will not have this difficult situation of perforation within a tunnel where the clip you have to put is difficult to put, and also it can prevent the end of the procedure later. So yeah, once again, for me it's more logical to do like this. Nevertheless, I use a lot underwater strategy during my progression, during my try to go to the center of the lesion. And it is a last example, last week, of muscle retracting sign management. With a large nodule, I couldn't find any connectory or geometry pattern at the surface, but those very large nodular lesions are somehow very difficult to analyze completely because there is a lot of mucus. So my strategy is to inject a lot. So I will do a very large incision relatively far from the lesion. If possible, I try to do it not in the slope, not in the heel, but more on the flat area, so entering under the lesion is easier. So I will do the dissection with a large pocket at the distal part. So yes, I will do a kind of tunneling, but relatively large. Immediately after, I will use a multipolar traction strategy on the edge of the lesion. My goal is to remove the 4 edges of the lesion from my field of view and see really the blue layer everywhere. So you can see that the wall is attracted by the lesion. We can see that we have a whitish tissue and it's difficult to find the submucosal layer because the muscle is really attracted to the lesion. So it is a difficult ESD. It's not a case for beginners or for relatively low experienced people. So don't begin by muscle retracting sign. It's a little crazy and you will probably be in trouble and be disappointed by doing this. So I do my trimming and my dissection on the oral edge after retroflexion. I put another traction on the oral edge on the 2 sides of the lesion. So once again, my goal is to remove the 4 edges from my field of view and to have more facility to enter into the submucosa. Here is the moment where I put my lateral traction on the edge of the lesion. Once again, my goal is to have only the muscle retracting sign at the end of the resection. So I use the rubber band to track the lesion to the opposite side. It will track the muscle, it's true, but on the opposite, it will help me to find the blue layer and to go faster also because by condensating the fibers, I will cut more fibers during each spike of the knife. So it is the strategy with multipolar traction. After this, I will go under, and I always help myself with underwater strategy to open the space, but we can see that traction helps to remove the field and to track the blue layer and see it better. So once again, I will try to have blue on the left, go to the muscle retracting sign, but let it, do it in the left part, in the right part, and then try to join the blue from the left and the right because it will help to find this virtual area at the middle. We will damage the muscle because it's difficult to do differently and to avoid any muscular contact, but at the end we will be able to cut muscles in the center, but relatively small area of muscle will be damaged, and we will close it immediately after. So you can see here that it is muscle in the middle. I prefer to finally go to the muscle and not to the lesion, even if I damage the muscle, because my goal is to be R0 at the end. So fortunately, we do this muscular damage at the end, so we will be able to close it quickly. That's also why I prefer to deal with the muscle retracting sign at the end and not at the early phase of the procedure. And once it's done, when you pass the muscle retracting sign, the weight of the lesion is attracting a relatively soft submucosa, so usually you see very clearly the area and the submucosa when you reach this muscle retracting sign and pass it. So this is the last example. In conclusion, the muscular retracting sign is something difficult to deal with, so it's not an ESD for beginners and for non-expert people. The definition could be a fibrotic retraction of the muscular layer toward the lesion, often centered on the fitting vessels with loss of submucosal layer, and we see it more frequently with macronodular lesions, particularly when nodules are larger than 20 to 40 millimeters. Please be careful if you have geometric pattern and sigmoid location, because the rate of deep invasion is really high. The ideal strategy for me is a circumferential incision and trimming and dissection, then a multipolar traction that remove the size and achieve the resection with the dealing of muscle retracting sign. Under approach could help at any part of the procedure, except probably dealing with the central feeding vessels, where a big bleeding will be difficult to deal with underwater. Muscle retracting sign is not cancer. Some lesions are completely benignant. Recognize it early will help you to choose the good strategy. For me, traction is a very important ally in management of this kind of lesion. Respect the central vessels as much as possible. You will do muscular damage, but you can close it at the end. So do it the later you can in order to close the perforation relatively quickly. And the goal is to have a safe and complete resection. Doing a damage on the muscle will not prevent a curative resection. Doing a lesion damage will probably prevent this R0 resection. So understanding muscular retracting sign, adapting your strategy, and master this ESD will serve your patient and avoid unnecessary surgeries. Thank you very much, and good holidays for those who will leave the endoscopy theater for summer break. Thank you very much.